Welcome, everyone. I would like to welcome everyone to one more National Dental PBRN webinar. Today, we will be talking about the FreSH study, the implementation and results. I'm so excited to hear the results. And as you know, the FreSH tested nicotine replacement therapy, and it was done in 3 regions of our network. Today, we have 2 investigators and 2 practitioners that will share the results and their experience with the study. And first, I will introduce our presenters today. We have Dr. Japuntich. She is a clinician investigator at the Hennepin Healthcare Department of Psychiatry, and she is also an associate professor at the University of Minnesota Medical School. Dr. Japuntich is interested in increasing access to smoking cessation treatment across different healthcare settings. And she is a clinical psychologist and the principal investigator for the FreSH study. So I would like you to welcome Dr. Japuntich, and she's joined by Sandra Helseth. Sandra is assistant professor in the Center for Dissemination and Implementation Science at the Northwestern University Feinberger School of Medicine. She is a behavioral health service researcher and a licensed clinical psychologist. And her work aims to reduce the impact of substance use problems through the development and dissemination of effective behavioral and technology-based intervention. She was responsible for the implementation science outcomes that were collected in the FreSH study. So she will be sharing that results in a few minutes. But first, we are going to listen Dr. Japuntich share the main results, the primary outcomes for the FreSH study. We are joined today by 2 dental practitioners who conduct the FreSH study, Dr. Gajendra and Dr. Narasimhan, but they will be introduced later on. But you are all very welcome here. I'm so excited to hear from all of you. Welcome.
Okay. Thank you for the introduction. Thanks for having me for this webinar. I'm really excited to share about the study, but first I want to say that I did not do this study alone. I did it with a Crackerjack team. Really grateful to the network for providing me all the support I needed for the study, and of course, my study team at Hennepin Healthcare and my co-investigators as well. And I particularly want to thank the practitioners who, this is not their job. They do this because it's a labor of love and because they believe in practice-based research. So thank you all for participating in the study, and also the node coordinators are really the lifeblood of the PBRN, and the staff at the NCC and ARC, and of course, the study participants who agreed to volunteer. So I'm going to share the background, a really brief background of the study. I have done a webinar about the FreSH study background before, which is available on our website. I'll share briefly the methods that we use, and then get to the good part, the primary outcome results, and then the process evaluation, and hear from the practitioners about what they think about what we found. So you all, I hope, know that smoking is detrimental to oral health. It is a leading cause of oral cancer, causes tooth loss, bone loss, periodontitis. We have 7 FDA-approved medications for smoking cessation that can double or triple people's chances of quitting in any given quit attempt. But unfortunately, people who smoke underutilize these treatments. Only about 1/3 of people have ever tried a smoking cessation treatment. Oral health providers are great at asking about smoking, usually during a health history, and advising to quit, but rarely provide smoking cessation interventions like prescribing medication. In addition, I have a soapbox, which is that we should be providing smoking cessation interventions to anyone who smokes, regardless of their willingness to quit. And the reason for that is that willingness to quit, or motivation to quit, is confounded between people thinking that quitting is important and people thinking that they are able to quit. And we know that if we offer treatment, people are more likely to think that they are able to quit and then more likely to make quit attempts and quit. So I'm interested in testing, or I was interested in testing an intervention called nicotine replacement therapy sampling, which means providing free samples of smoking cessation medication during routine healthcare. Giving out free samples of nicotine replacement therapy shifts the focus from the providers feeling like they're shaming or blaming people for smoking to providing concrete support, something that might help right in the moment. We think it would work for a number of, so it is effective. Nicotine replacement therapy sampling has been shown to be effective in primary care. And by increasing smoking cessation rates by about 50% 6 months after people got the sample. And we think it works for a number of reasons. First, I think that it makes more conversations about smoking cessation happen because providers have something to give patients to talk to them about and a reason to bring it up. Second of all, it might motivate people to quit smoking because they now have a tool that might give them higher self-efficacy to quit. And third of all, if they do make an attempt to quit smoking, with many people who smoke do every year, they will do it with an evidence-based treatment, which makes it more likely that the intervention would be successful. So the purpose of the FreSH study was to see if this intervention that worked in primary care would also work in dental settings. And we got the idea because when we go to the dentist, we get free samples from the dentist. And so we thought, dentists kind of do this already. Okay, so just a reminder of our study goals. If you didn't come to the last webinar or are not a practitioner in the study, our overall aim is to test the effectiveness of providing free samples of nicotine replacement therapy in addition to a brief intervention called Ask, Advise, Refer, which I'll talk about a little bit later, on long-term abstinence from combustible cigarettes. And we compared that to the same brief intervention, but instead of nicotine replacement therapy, we gave another oral health product, an electric toothbrush, just to equate the two groups. Our goal was to recruit 1,200 adults who smoke who were visiting 50 dental practices in the Midwest and Northeast regions of the National Dental PBRN. And our primary outcome was whether or not people were smoking 6 months later. And we confirmed cigarette smoking using a carbon monoxide monitor that was connected to a smartphone. Carbon monoxide is a byproduct of combustion, and so can help us determine whether people are smoking or not. And then we also looked at secondary outcomes like short-term abstinence after we gave people the sample, quit attempts, nicotine replacement therapy use, use of the state quit line, and then the implementation outcomes that Sarah is going to talk about later. So this was what's called a UG3, UH3. So there was actually a 2-year setup phase before, but we started the UH3 phase, the clinical trial phase, in January 2023. We began recruitment in April 2023, and we collected our final primary outcome data in June 2025, and we're in the data analysis phase right now. So participants in the FreSH study, this was a practice randomized study, which means that we recruited practices and then the whole practice either gave out free samples of nicotine replacement therapy or free electric toothbrushes. The practitioners, who could be dentists, dental hygienists, or dental therapists, screened patients for eligibility, anybody who smoked cigarettes. We had very broad inclusion-exclusion criteria. They had to smoke at least 1 cigarette per day on average to be part of the study. They were then consented in the dental office and completed a baseline survey. Practitioners delivered the intervention, which took about 7 minutes or so on average. And then we had follow-up surveys after the visit to make sure that practitioners did what they were supposed to do. And then at 1, 3, and 6 months post-visit. If participants self-reported abstinence at the 6-month outcome or primary outcome, we then sent out a carbon monoxide test remotely. Okay, so all practices in both conditions did the American Dental Hygienist recommended brief intervention for smoking cessation in dental practices called Ask, Advise, Refer. Practitioners were told to ask about tobacco use for every patient, advise patients to quit in a strong, personalized, and sensitive manner, and then refer patients to the state quit line, either through a fax referral or a web portal referral for people who are interested. So you can see the script here. It says, do you smoke or use tobacco products? I take the time to ask all my patients about tobacco use because it's important. Quitting smoking is the best thing you can do for your oral health. Cigarette smoking can cause gum disease, tooth loss, and oral cancer. Quitting smoking will allow these problems to start healing and prevent future damage. And then if you're willing, I'd like to place an electronic referral to the state quit line, and then some description about the quit line. The nicotine replacement therapy group gave out free samples of nicotine replacement therapy, a 2-week supply. So that was 14 days of nicotine patch and 81 lozenges. People can use about 9 to 20 lozenges a day if they use them alone, or 5 to 9 if they use them together. They were given very brief use instructions. They were told that these are products that can help people quit, that people can use them alone or together, but they were encouraged to use them together, even if they're not ready to quit. And then they were given some suggestions of how they could use them, although told they could use them however they like. And the suggestions were to reduce smoking, to get started on quitting, to make a practice quit attempt, or to use during times when they can't smoke, or just to try them out to see if they like them. And then they were told how to use each, both verbally, and then they were given instructions in their materials. I want to note that we did not tell practitioners to ask people if they were motivated to quit in order to be in the study, or to get the samples, or to be referred to the quit line. This was really just for all comers, and that simplifies things 2 ways. One, if this were implemented in a dental practice, you wouldn't have to bother to know who should get the samples or not. And 2, because I think that giving people access to treatment can change their motivation to quit, or help them when they have motivation to quit later to make a supported quit attempt. So the sample bags were this tote bag with our FreSH logo. FreSH stands for Free Samples for Health. So there was nothing about smoking on any of our logo materials to ensure privacy. The bag had the toothbrush or the nicotine replacement therapy, some information about the study, an ADA brochure about smoking and oral health, information about stop smoking medicines was given to both groups, and then some swag so that they remembered that they joined a study. Okay, so we're on to results. So this was the study flow. So we, as you may recall, planned to enroll 50 practices, but we actually enrolled 59, about half-half in each, were randomized to each condition. You can see that they approached a number of patients and then consented and gave the baseline survey to 1196 patients, and then delivered the study intervention. You might notice that the NRT conditions practices recruited fewer people than the electric toothbrush practice, which I thought was interesting. And then our survey response rates were good, ranging from like 90% to around 70%, and about 70% completed the CO test when asked. Okay, our practices again were in the Midwest and Northeast regions in the National Dental PBRN. They comprised 89 practitioners, so some practices had multiple practitioners. They spread across the Midwest and Northeast region with some clusters where our nodes are at Health Partners in Bloomington and University of Rochester. In terms of what the practices look like in FreSH, the practitioners were 62% female, more female hygienists than dentists. About half were general dentists, a third hygienists, which is super exciting because this is one of the first PBRN studies that hygienists could be practitioners for. We had some dental specialists and 1 brave dental therapist. The nodes were split about equally, with a few more practices in the Northeast. Practices tended to be urban, but we had some rural practices as well. Other practices didn't differ on any of these variables. Oh, and practitioners were on average in their mid-40s. In terms of patient demographics, they tended to be more female than male. We see that in a lot of studies where women are just more likely to sign up. They were in their mid to late 40s. We see that in a lot of smoking studies. 40s are when you start to see health effects of smoking that motivate you to quit. And then they tended to have a high school education on average, and they were demographically similar, the two groups. We did, however, see differences in smoking heaviness or cigarettes per day, confidence and readiness to quit, including the likelihood that participants were ready to quit in the next 6 months. So all of the confidence, readiness to quit variables favor the nicotine replacement therapy intervention, suggesting that that intervention enrolled more motivated people. And also people in the NRT condition tended to smoke more cigarettes per day or be more dependent. In terms of treatment fidelity, we tracked a number of variables about how practitioners interacted about smoking to the patients. This was collected in the after visit survey that was fired off right after they participated in the study and was to be completed in the first 72 hours. Not surprisingly, almost everybody said that they were asked about smoking because they couldn't be in the study if they weren't, and most were advised to quit. Surprisingly, most were also asked about readiness to quit, despite the fact that I stood on my soapbox and said that they didn't have to be ready to be part of the study. More people were asked about readiness to quit in the NRT condition. So the NRT practitioners seemed to want to recruit more people who are more ready, as we saw in the results. And then we see intervention, manipulation check of the intervention. Only the NRT condition was much more likely to discuss medication, advise medication, and provide any medication. And then about 2/3 were referred to the quit line, more in the NRT condition, likely reflecting that they were more motivated to quit. Okay, and here are our primary outcomes. So we saw a significant effect of nicotine replacement therapy samples at the 1-month time point, with more people quitting in the nicotine replacement therapy condition self-report. But then that effect washed away at 3 and 6 months, and you can see the last one is our CO confirmed. So about half of the people who said they were not smoking completed a CO test that showed that they were not smoking. In terms of secondary outcomes, we saw a significant effect of quit attempts from the NRT samples, both ever in the study and in the first month post-quit. We also saw a significant effect favoring the electric toothbrush condition the NRT condition that's in green. Electric toothbrush is in orange. So we saw more NRT use in the electric toothbrush condition, both patches and lozenges. We also saw more quit attempts in the NRT group, and no difference in quit line use, although interestingly, it looks like a little more quit line use in the electric toothbrush condition. I think probably because we didn't give them another intervention. So if they were motivated to quit, they would use the intervention that we gave them. Okay, this is about how people liked the nicotine replacement therapy. There's kind of moderate favorability. So this is a scale of 0 to 10, where 10 is the best and 0 is the worst. And people were kind of right in the middle, with a little bit more favorability and effectiveness to the patch than the lozenges. When we interviewed people, which Sarah will talk about, people really did not like the flavor of the lozenges. In terms of why they used the samples, even though we told them they could use it for whatever reason they wanted, most people used it to quit or reduce. About half of people who were in the nicotine replacement therapy group actually used a nicotine replacement therapy sample. And of those, about half bought more NRT afterwards. So the sample strategy worked to promote new users. All right, I'm going to kick it over to Sarah to talk about the process evaluation or implementation results.
Thank you so much. Hi, everybody. So really quickly, for those of you who aren't familiar with implementation science, it's really the study of how to accelerate and kind of capture the context in which an intervention occurs. So figuring out how to get things out to people who need them faster. So in this case, we were looking at whether or not providers felt that their organization, in this case, their practices, felt ready to implement these changes. We measured that before and after the study. And you'll see in these numbers that overall, people reported that they were ready to make these changes, but that we did see a slight decrease in reported readiness to change. And that was particularly notable among dentists, whereas hygienists relatively kind of stayed the same over time. So that was a really exciting effect for us to find. It suggests that maybe dentists in particular found this intervention more challenging to deliver or more time consuming perhaps, or maybe hygienists found it easier to deliver. And something to note too is we were looking before versus after. And so before, it's more asking people if they think this would be something that they could do and they're ready to do this. And then after is after they've really been trying doing it and they understand some of the challenges that they might face otherwise. We also tried to capture perceived feasibility of the intervention. So can this be done? Acceptability, whether or not the practitioners liked the intervention, and appropriateness, whether or not the practitioners thought that this intervention was appropriate for their setting. And overall, we did not find changes in their feasibility, acceptability, and appropriateness before and after. So that suggests that we didn't see that same drop that we did in the readiness outcome. The other thing I did want to mention, which I'm not showing on this slide here, is that patient satisfaction ratings. We asked patients how much they liked each intervention in the nicotine replacement therapy sampling condition and in the electric toothbrush condition, and they didn't differ. People were just as happy to receive one intervention as they were to receive the other. And so then what we did was we spoke with a subsample of our providers who delivered the NRTS condition. And we spoke with patients who received that condition. Most patients reported that they'd never previously tried nicotine replacement therapies, either because of the cost or because they weren't interested. And many opted to participate in the study because they were interested in trying to change their smoking behavior, and that it's possible participating in this study gave them the little push they needed to maybe try a sample that they had received, or maybe make a behavioral change and try to cut back. Patients reported that they felt the intervention was appropriate. Some were actually surprised that they were being given free samples by their dental practitioners. And they overall felt that this would be appropriate to do in other dental settings. When we spoke with the providers, they all agreed that smoking cessation was relevant to dental practitioners and dental care. They told us that prior to the study, they felt like they lacked the tools or some of the knowledge and were therefore wary of speaking with their patients about smoking cessation. Hygienists reported that they had received prior training, whereas dentists reported that they really hadn't received too much training. So that might be another opportunity for us to try and refine the intervention before future iterations. And overall, the practitioners reported that they found this really easy to deliver, especially in those preventive visits, because they had more time to be able to, take the 10 minutes it would take to do this intervention with their patients. Overall, they indicated that they would recommend this nicotine replacement therapy sampling to their colleagues. And they plan to continue trying to deliver smoking cessation services in their practices, though they did note some concerns about time, the cost of those samples, and then just in general competing priorities. And I think Sandra's going to come back to talk about the conclusion.
Thank you, Sarah. So overall, we found that nicotine replacement therapy sampling increased nicotine replacement therapy utilization, quit attempts, and short-term abstinence, but not long-term abstinence. So nicotine replacement therapy sampling worked. It worked exactly how we thought it would by increasing nicotine replacement therapy use and quit attempts and even abstinence, but the effects didn't persist long-term. So we're thinking about why that would be and why that's different than primary care. One possibility is that something about the intervention wasn't good enough. Either they didn't like the samples, they weren't the right thing to give them, is a possibility. Matt Carpenter, who did the first nicotine replacement therapy sampling trial and is a co-investigator on the study, has done sampling for other things that for smoking cessation, including varenicline or Chantix, including e-cigarettes even. So it's possible that patients would have liked a different thing better. It is possible that we didn't give them enough, that a 2-week supply wasn't enough to promote long-term abstinence. Nicotine replacement therapy is supposed to be given for 10 to 12 weeks minimum. And so maybe they used it for the 2 weeks they had it, and then afterwards went back to smoking. I also want to note that, and then there's other types of sampling that have been done. So maybe we want to get more people to use the sample. In our trial, 50% of people use the sample. In the primary care trial I talked about before, 67% of people use the sample. So maybe we need an intervention where we get more samples in or on more bodies. Some people have tried, including Karen Cropsey at University of Alabama, actually, have tried to do what's called in vivo sampling. So actually having people use the sample during the office visit. So you could imagine if a patient comes in for their cleaning, you could put a patch on them, or as they leave and they've been withdrawn for an hour, you could have them try the lozenge. Just to put more people in the top of that funnel of initially trying it to get enough people at the end who actually quit. Another thing to note, though, is that the sample that we got for the National Dental PBRN patients was higher in education and higher in income than the primary care sample. And so it is possible that in this sort of healthier, more resource sample, referring them to the quit line or just giving them brief advice to quit is enough. It's possible that dental patients in general are more health conscious than primary care patients, because people go to primary care when they're feeling sick. And in dental practices, there's a lot of preventative care being done. So those are some ideas we have for that. On the practitioner side, we found that both practitioners and patients thought that nicotine replacement therapy was feasible and acceptable. But dentists differ from hygienists, as Sarah said. So it seems like hygienists felt more comfortable talking about smoking. It also seems like from what we found with our differential recruitment rates in the nicotine replacement therapy sampling condition, and also the recruitment of people who were more motivated to quit, that practitioners had a harder time having a conversation about smoking when they were providing an intervention, which shows a lack of comfort with talking to people who don't want to quit about their smoking. So we found that interesting as well. The sample was supposed to change the conversation. And in fact, compared to the primary care trial, which didn't have a gift in the control condition and then recruited fewer people in the control condition because of it, we thought that we would get equal recruitment because both sides were giving a gift, but it seemed like the practitioners didn't feel like the gift was as easy to give when it was about smoking instead of about oral health. So those were the interesting conclusions we have. I'm gonna kick it back to Joanna to introduce our panel.
Thank you, Sandra. This was an excellent presentation. I'm really excited to see the results from the FreSH study. Okay, so now we would like to hear from our practitioners. We have Dr. Dhanya Narasimhan from Health Partners Dental Clinic in Bloomington, Minnesota, and also Dr. Sangeeta Gajendra from Eastman Oral Health Institute in Rochester, New York. So welcome, Dr. Narasimhan and Gajendra. We would like first to hear your experience, how was on doing the study. So Dr. Gajendra, would you like to start?
Sure. I've been a member of the PBRN since quite some time, but this study really caught my eye because I have really been interested in tobacco cessation and trying to get our patients to quit. I've been involved ever since I was faculty at the Eastman Institute for Oral Health. Also, the study was interesting because it was giving freebies to my patients. Very easy method to implement, and I thought it would really benefit my patients a lot. And I really wanted to see, does it really work? Like giving freebies, is that something that? And I'm glad to see your results because it worked. And so, yes, that's why I joined your study and was interested.
Thank you. Dr. Narasimhan?
First of all, I really want to thank you all for letting us all be a part of this amazing study because it's so relevant and so practical and so easy to do. I really enjoyed it, and I felt like I felt like when I was talking to my patients about it, it's at a dental office it's less intimidating to talk about smoking than at a primary care. That's something I felt. And I felt like, we see our patients every 6 months, so it's easier to bring up this conversation and check in on them. So these were little things that I felt. And I also felt that, because for the first time I had some samples, I had some information to talk about, like the care line, the quit line. I felt like I had some resources to provide to patients about it, because I think as all dental practitioners, we all care, but we don't have the tools in our toolkit. But the part in the study where it said that, we can talk about it afterwards, but the part in the study where it said that the results were surprisingly not too different, I feel like we weren't focusing on the motivated people, and smoking is such a difficult habit to get rid of that maybe that's why it's a multifactorial thing. So there's so many different things, that it's social aspects, their personal lives, so many different things. So I kept telling my patients, it takes a few attempts before you get. But thank you.
Yeah, it's very nice to hear your experience. So how did the patients receive the electric toothbrushes and the information about the quit line?
I think they were very well received. They loved the electric toothbrush. As soon as I would show them the box, there would be a big smile on their face. It was a very nice reaction, and I knew that this would work because we talked about how the electric toothbrush does the work for you. You don't have to worry, and it will tell you, there's a timer. It will tell you 30 seconds and 30 seconds and 30 seconds and 30 seconds for each quad. So it's exactly 2 minutes. If you're less, the timer is going to warn you. And they really, I think, they accepted it very well. They were looking forward to that. And it's a great idea to give freebies.
Okay. Yeah. And then did you start asking patients more about their smoking and the use of the ask and advice or
and refer.
having a process? Did it make a difference with other patients?
Definitely, because I think in some ways it's kind of like motivational interviewing, right? Where you motivate the patient to do something, and that's exactly, you talk about the ill effects of smoking, but you don't tell them you need to quit or you need to. You ask them how do you feel about your teeth and about your body, and that kind of. And that's what was a little different than my usual patient care before this study. And yes, ask, advise, and refer were being used even before, but it was different with this study because we were actually emphasizing on how they can do it and what you need to do to actually quit. So it was very interesting. I really enjoyed this study, being part of this study.
I just wanted to add that in the study results, it was nice to see that, I was a part of the control group that received the electric toothbrush. And then it was interesting to see that more people from the control group did contact the quit line. And that feels like a victory to us because, there is just giving them the tools and giving them some information, motivating them, even with the toothbrush, like this, you have to care about your oral health. And so I think that did result in them following up the ones that did. So I think that's a good outcome, even though it's different from the other group.
Yeah, well, thank you for sharing that, your experience in the study. Let's have Dr. Japuntich and Helseth join us now, and we will be answering a few questions from the audience. But Dr. Japuntich, I would love to hear what comments do you have about the experience from two practitioners who were in the control group and started using more the ask, advise, and refer with their patients, and how that compares to the results of the study.
Yeah, I love that. And I have read Dr. Gajendra's work on smoking. So thank you for your contribution to the field. So yeah, I think we had maybe had some ringers in the control group who were a little bit more comfortable talking about this, which is, hard in a cluster randomized trial. And we did hear, and Sarah can comment too, but we did hear from control group practitioners that they really got into the ask, advise, refer, and they learned the process and they kept doing the process afterwards. And even, I guess we didn't hear that from the control group. We only interviewed the intervention group. But anyway, we did hear that people, after they didn't have samples anymore, they had planned to continue referring to the quit line because they learned the process. So that was really heartening to hear. And we did have one participant tell somebody who did a follow-up survey that they found the toothbrush to be a helpful reminder that they were wanting to quit smoking. So I don't know, that's possible too.
I love that.
They were not quit, so I can't recommend that as a treatment, but they did say they felt like their answers didn't reflect how helpful the study was because they did think more about their oral health every night when they brush their teeth. So that could also be a thing that happened.
Yeah.
Yeah, and I did see in the chat somebody saying they wanted to know how to access resources for their patients. And during the FreSH study, every state in the United States has a quit line. You can, if you're in one of the Midwest or the Northeast region, we have a tip sheet on how to refer to the quit line that you could ask us for. If you're in other states, you can Google the state quit line and there should be a way a practitioner can refer. And during the FreSH study, all of the states that were involved in the FreSH study did offer free nicotine replacement therapy to people who enrolled in the quit line. So if you're interested in getting free nicotine replacement therapy for your samples, I would check your state quit line and see if that's still true. I will say the CDC cut the Office of Smoking and Health, which supports the quit lines. So there were some program cuts, but as far as I know, there are still state quit lines out there, but they may not have the money to offer samples at this time. So check with your state. It depends on how their quit line is structured.
Are there any websites where there are materials for the ask, advise, and refer?
That is a great question. I would have to look that up. But it is recommended by the American Dental Hygienists Association. There are, like sort of published articles about it.
And the American Lung Association also has some really helpful resources about ask, advise, refer. So that could be another resource.
I have a question to Dr. Japuntich.
Yeah.
You did the study in primary care, and
I didn't, but other people did.
Okay, other people did. Like other co-investigators in this team of did studies in primary care, and we did find some similarities, but also some differences, and you alluded to them in your conclusions. Can you expand a little bit more on what are the rates of quitting in primary care and dental care, and if what else, maybe the practitioners here may have some insights of what could be different in the environment of the dental and medical.
Yeah, I have this hidden slide about that, Joanna, which I skipped because I didn't know if people would be interested. So in green is the FreSH study, and in purple is the TIP-TOP study, which I don't know what it stands for, but that is Matt Carpenter's primary care trial. So the FreSH study actually did better, had a higher difference in promoting nicotine replacement therapy use. So dental patients in general didn't use nicotine replacement therapy in the control group compared to primary care. And I think that is because primary care providers are used to prescribing nicotine replacement therapy and dentists generally don't. So this, even though we had a lower rate of use, this is actually a bigger difference between the two. But you know, more people use nicotine replacement therapy in the primary care sample than did in our control group. However, we did much better in quit rates across all of the time points for the dental clinic. These patients just were much more motivated to quit or much more reactive to a dentist telling them to quit. And the difference washed out over time. There were differences in the study protocol. So for example, because of what we found, what Matt found in the primary care trial, he felt like not enough patients used the samples early. And so in our script, we told people to use them within a month. So it's possible that we got all of the juice out of the nicotine replacement therapy samples that first month, and then over time it decreased. That's one possibility. Another possibility is that people aren't used to their dentist talking to them about smoking, and maybe just talking to them about their smoking is enough because it's new. We know that the more provider types that talk to patients about smoking, the more likely they are to make a quit attempt because it's harder to write off. And we also know that the effects of smoking on oral health show up earlier. And so you can really show them concrete problems in their teeth because of smoking, like yellowing, things that like people care about. So it could have been that too. But we did, as I said, find socioeconomic differences in our sample, with the dental patients having more income and more education. And so those people just have more resources. So maybe they didn't need something for free. I also just want to highlight a practitioner comment that I saw in the chat, that they said their patient actually came to their office and said, like, I changed my address and I want the study to know. So, you know, we had people who really wanted to quit in the study. And I think the motivation to quit of the patients in the FreSH study was higher too. And so if you're more motivated to quit, you're more likely to quit, you know, whether or not an intervention is given. And everybody got, the other thing that was different between our trial and the primary care trial was they gave out information to the quit line. We taught people how to refer to the quit line. If you directly refer to the quit line, patients are much more likely to be connected to the quit line because they don't have to do any work and nobody wants to make a phone call. So if they get proactively called, they're much more likely to use it. So we taught the practitioner to refer directly to the quit line, either by fax or by entering their name into a website. And then the quit line would call them. And so you're kind of like, even if you have someone who's like kind of 50-50 on whether or not they want to call the quit line, or they get busy and they forget, like you've already set it up so that the wheels are already in motion.
Okay, yes,
so
that's so important because it's not initiated by the patients. It's initiated by the quit line personnel calling them. Of course, they need to pick up the phone for sure.
Right, and again, like not a lot of people use the quit line, although 1 to 2% of people use the quit line a year of the population. And I think we found like, you know, there was like 6 and 9%. So like, it's not a lot of people, but it's kind of a lot of people comparatively. And the other thing I found interesting was like, we really, even though we saw more quitting in the control group or the electric toothbrush group, we didn't see more NRT use. So this quitting is probably cold turkey kind of quitting, or quitting with support from the quit line. But it's not all support from the quit line because only 9% of people use the quit line. So some people quit some other way.
And Sandra, I think from an implementation perspective, when you look at these rates, and especially you look at the drop in quit attempts from 1 month to 3 months to 6 months, I think the utility of the nicotine replacement therapy sampling is that it's removing barriers for patients. It's making it that much easier for them if they are motivated to make a quit attempt or to try and reduce and cut back. And so if perhaps, like you mentioned earlier, if we gave more samples, we might see longer effects to a 2-month or a 3-month time point. Because something I heard when we were speaking with some of the patients is like, they wanted to keep using samples, but once they're back in the real world without someone just handing them a gift bag with the things they need to make that attempt, they still have to deal with navigating those challenges. So if they wanted to get a prescription and get it funded by their insurance so that they didn't have to pay for it, because it's actually fairly expensive for a lot of folks. I think those are all things that we have to consider as we think about the next steps of this project, is what can we do to make it easier, but also make it still resemble kind of the challenges that they'll face, or help them figure out how to navigate those challenges if they want to, after we give those samples. Anything we can do to try and raise those rates a little bit would be really powerful, I think.
Yeah, I saw actually Dorota put in the chat, what would we do differently if designing the study again? And I think I want to answer that by saying, like, what am I thinking would come next from this? And I think one thing is what Sarah said, right? That the sampling mechanism is fleeting and we need something more sustainable. And so if you prescribe nicotine replacement therapy, especially if a patient has like a mail order pharmacy, right now, nicotine replacement therapy, if you prescribe it, is covered without copay and most insurances because of the Affordable Care Act. So trying to get it like through a mail order pharmacy, so the nicotine replacement therapy samples just come in the mail through the mechanisms that already exist. And the other thing that struck me was when we planned the FreSH study, the dentist said they didn't really know how to prescribe for smoking cessation. So that's an implementation challenge I'm eager to tackle. And then also thinking about this difference between hygienists and dentists, and how do we get either dentists to have more comfort talking about smoking, or how do we get the hygienists to tee up the dentists, to talk about smoking and talk about the opportunity for prescription and then having the dentist prescribe? Or how do we do a referral to primary care that's not dependent on the patient? Because like I said, proactive approaches like direct referring to the quit line work better. So if we're gonna say dentists are gonna tee it up and primary care providers are gonna manage it, then how do we make that seamless so that we don't lose people? In terms of what I would do different designing the study again, I would say the cluster randomization was hard, because it turns out that sometimes people change their jobs and move to different practices. And that was hard, working in the PBRN and having people move around and having to set up a study in a new practice. So that, I don't know, I might have just randomized the practitioner instead of the practice.
Thank you,
Sorry,
Dr.
Joanna.
I was going to ask Dr. Gajendra or Dr. Dhanya how when they hear your next ideas for studies, what are their inputs in terms of those insights that you had for a new study?
I had actually a question, because I'm listening to the results, and the only thing you bring up why there is a difference between dentists, hygienists, and we have limited time, and when we see our patients, the part that's really important is the motivation. And I'm just trying to understand here. So the goal is, if we provide samples and keep it within their, it's like providing the exercise machine and just hoping the patient gets on it. Is that how it is? And it's supposed to work. Is that right? Because that's the part that I was a little confused about, because I was like, I need to know where the patient is at this point. I can provide them the tools, but are they going to be using it? Or and that's the part that hesitate, before I go on the whole talk about, and we can tell them it's bad for them, but to provide tools, are they ready for it? And so is that important or not really?
Well, one thing is that exercise is it's a multi-different, there's many behaviors involved in exercise versus sticking a patch on your arm, I just want to say.
Okay.
But you're less likely to ride an exercise bike if you don't have one, right? So
Right.
I feel like this is a brief intervention. It is not going to get the quit rates it would get if you went to 12 weeks of therapy to talk about your smoking and an intensive. This is not intensive. We're trying to, on a population level, try to get more people across the goal line. That said, I think that asking patients about their motivation to quit doesn't matter. I mean, I don't want to say it that strongly, but because patients who think that they cannot quit will tell you they're not motivated to quit because they don't want to disappoint you. So trying to get, if you ask patients, do you want to make changes in your smoking? You're much more likely to get a yes than if you ask patients if they want to quit. Because most patients have tried and failed. That's the nature of the beast, as you said. And there have been studies that have looked at patients reported motivation to quit without being offered an intervention or after being offered an intervention. And if they're offered an intervention, their motivation to quit changes. And so that tells me not to necessarily push it, but to say, instead of saying, do you want to quit, saying, here at Health Partners, we have a number of options to help people quit that are great. Like they're covered by your insurance without copay. I can start them right now. You don't have to commit to anything, but if you want them, they're there. I think is a good sales pitch.
That's absolutely very good to hear, because I think that it's easy to do. And I think we see patients every 6 months, and it's easy to kind of touch base and check in on them, which I think that if you go to a primary care, you don't get that option. So it's really it's a good place. I feel as dentists, we have, my hesitation was I felt like I knew very less about it. I didn't know if they asked me any more questions about, okay, if I try, what can I do this to try? Or I just felt I had less information on the other methods of quitting if they asked me about it. But I think that, we see them every 6 months. It's a very casual environment. We can definitely promote and encourage them to take, participate in this, because it's absolutely great for their oral health and then their overall health too. So thank you for giving me that information that, yeah, if you provide it to them, their motivation is up, just because we believe it, that we give them a tool to work on. So it's good to know that.
I just want to add something to what you all have discussed, that if you actually do a 3 to 5 minute, smoking cessation promotion with your patient, it is billable. It can be reimbursed by your insurance companies. Medicaid also has a billable code. Not many dentists know about that. So you want to check, your state Medicaid. You want to check your private insurances, because I think people tend to say, oh, we don't have the time, and so and we don't get reimbursed, but they're not aware. So that would be one of the things to really help dentists be aware, as well as hygienists, that this is some billable, and that you can always do it in your practice, and it won't hurt. In fact, it's just a 3 to 5 minute intervention that will help.
My understanding, thank you so much for saying that. I really think that is important information. My understanding is you have to bill it as a medical code. You have to be set up to bill it medical codes. No,
ADA, it's a regular Medicaid, and so dental offices can bill. So
I would like to thank everyone that attended the webinar today. Especially thank you for our 2 practitioners and the 2 presenters. Do you have anything else, though, just some final words for our attendees? We would love your feedback as well. So any one of our presenters and panelists, would you like to share some final words?
I just want to echo what the panel said, that smoking affects oral and physical health, and even just telling patients that treatments available can improve quit rates and save lives.
Then the more you talk about it, the more likely that the patient is going to quit. So please continue the good habit.
Yeah, you can think of it like every time you talk about it with a patient, you're reinforcing that skill for yourself, and you're also helping someone gain the knowledge that they might need to make a change whenever they're ready, whether it's this visit or 6 months later or a year later.
And it's so good to know as a dental team, we have such positive impact on our patients. So we need to take our role really, you need to take it, take responsibility and do our best to help them and, help our population. It was really nice to know that we could have such a big impact compared to the medical. And so I will for sure take this forward and try my best to help our patients. So thank you so much for sharing such an interesting and such an impactful study. Thank you for doing this for all of our people.
Thank you.
Thank you.
We will see you next time. Bye.
Bye, everybody.